Hello everyone. Today my lecture is on apicectomy. Apicectomy is the surgical resection of the root tip of the tooth and its removal together with the pathological periapical tissues. Accessory root canals and additional apical foramina are also removed in this way, which may occur in the periapical area and which may be considered responsible for failure of the endodontic therapy. Indications: teeth with active periapical inflammation despite the presence of the satisfactory endodontic therapy. Teeth with periapical inflammation and unsatisfactory endodontic therapy, which cannot be repeated because of various ways, such as completely calcified root canal, severely curved root canals, presence of posts or cores in the root canal, breakage of a small instrument in the root canal, the presence of filling material which is irretrievable. The teeth with periapical inflammation, where completion of endodontic therapy is impossible due to foreign bodies driven into the periapical tissues, perforation of the root, fracture at the apical third of the root tooth, and dental anomalies. Surgical root canal procedures should not be considered as the primary treatment options to treat the teeth with associated apical pathology. Here are the pictures which show the periapical lesion at the maxillary right lateral incisor, which is indicated for apicectomy, and clinical petrograph. Second one is in which arrows are pointing out to show the possible location of the lesion. The lesion may be due to the overextending gatapacha cone. Lesion may also appear due to the improper apical seal, such as this is the radiograph of the maxillary central incisor showing the periapical lesion and unsatisfactory filling of the root canal. If after the apicectomy the apex is not completely sealed, then retrograde filling is required. The purpose of retrograde filling is to obstruct the exit of bacteria and the byproducts of non-vital pulp, which remained in the root canal. Contraindications of the apicectomy are all the conditions that could be considered contraindicated for oral surgery concerning the age of the patient and general health problems such as severe cardiovascular diseases, leukemia, tuberculosis, etc. The teeth with severe resorption of periodontal tissues are contraindicated for apicectomy. Teeth with short root length also contraindicated. Teeth whose apices have a close relationship with the anatomical structures are also contraindicated for the apicectomy. Armamentarium the following instruments are used, such as handpiece, mirror, periostal elevator, cotton plus, small hemostat, suction tips, tubes, needle holder, retractors, etc. These are the handpiece, periapical curettage tips, amalgam applicator. Instruments and materials for retrograde fillings are shown in the figure. Ultrasonic scaler may be required for root and procedure cleaning, well centered and more conservative root and cavities than conventional rotatory instruments. Surgical technique. The procedure for apicectomy includes the following steps: designing of the flap, localization of the apex, exposure of the periapical area, and removal of the pathological tissues. Then we do the resection of the apex of the root tooth and retrograde filling if necessary. Then wound cleaning and suturing is done. Flap design depends on the various factors which may include position of the tooth, presence of the periodontal pocket, presence of the prosthetic restoration, and the extent of the periapical lesion. There are three types of flaps principally used for the apicectomy: semilunar flaps, first one figure, triangular flap, or trapezoidal flap. When apicectomy is performed in the anterior region, such as maxillary central incisor, the size of the lesion is small, and when there are aesthetic crowns on the anterior teeth, the semilunar flap is preferred. This in this pictures, the incision is shown. Um this is semilunar incision. The next step after the flap is localization exposure of the apex. When the periapical lesion has perforated the buccal bone, localization and exposure of the root teeth is necessary. After removing the pathological tissues with the curettage, if the buccal bone covering the lesion has not been completely destroyed, but it is thin, then the surface is detected with an explorer or dentacurate. When due to the decreased bone density there, the underlying bone is easily removed and the apex is localized. Removal of the bone covering apex of the tooth. This is the diagrammatic representation. Exposing the periapical lesion in the third one. Removal of the labial bone covering apical third of the tooth. Then periapical periodontitis in the body is a natural immune response to the inflammatory mediators and infective agents within and around the root apex. Thus, no matter how thoroughly the granulation tissue that forms the PRD lesions is removed from the surgical site, unless the actual source of infection within the root canal is addressed by the root resection and retrograde restoration, the surgery will likely fail. The presence of many different foreign body materials has been reported. These include of particularly interest the remnants of paper points caused by inadequate measurement during the root canal preparation procedures and vegetable materials entering the exposed root canal when a tooth is left open for drainage. This procedure is open drainage and is no longer recommended. It is better to remove the lesion as one piece. Removal of the periapical lesion with the curate is showing in the figure. This is the periapical lesion which was find out after the periapical curettage. Then root and resection is done. Main reason for surgical approach to the endodontic problem is to remove the extra radicular bacteria and other contaminants causing the clinical symptoms. However, the anatomy of the root apex is complicated with the multiple portals of the exit and accessory canals. Indeed, the presence of apical ramifications may be a major contributing factor towards the occurrence of refractory ARDs. So, apical curettage is very necessary and roots resection is properly done. Here the root resection procedure is showing in the figure. It is then obliquely cut so that it increases the surface area for more filling. Then retrograde filling is applied for proper apical seal. Placement of the filling material in the cavity of the apex using amalgam applicator is shown in the figure. Then wound cleansing and closure of the flap is done. After placement of the amalgam, the gauze is carefully removed from the bony defect and copious irrigation with a saline solution is done. A radiographic examination is performed to determine if there is amalgam scattering on in the surrounding tissue. The flap is repositioned and the adapted sutures are placed. Healing the periapical area is checked every 6 to 12 months radiographically. Using ossification in the cavity is ascertained. In order to evaluate the result, a preoperative radiograph is necessary, which will be compared to the postoperative radiograph later. The radiograph taken before suturing of the flap, which shows retrograde amalgam filling. Thank you.